Good afternoon, dear professors and colleagues. My name is Ola Abdelhamid, Assistant Lecturer in Qasr Al Aini Hospital, and today I will be talking about a case of MS with unexpected twist. Our patient, male patient, 44 years old, smoker, diagnosed with MS since 2002, with first attack in form of double vision, and recurrent attacks in form of left-sided weakness. Our case, male patient, 44 years old, smoker, diagnosed with MS since 2002, with first attack in form of double vision and recurrent attacks in form of left-sided weakness or numbness. The last attack was on 2014. He was treated by interferon till 2017, then stopped due to infrequent attack, with the current EDSS 0. The patient was diagnosed according to MRI brain that showed typical MS lesion and MRI cervical showing short segment lesion. Also, CSF showed positive oligoclonal bands. In December 2024, our patient experienced olfactory hallucination in form of burning smell for 2 weeks. Then he experienced 3 serial seizures. When the patient recovered from seizures, he complained from right side weakness, right homonymous hemianopia, and mental slowness. MRI stroke protocol, CSF, and EEG were done. The MRI stroke protocol and the vascular imaging were normal. CSF, TLC, glucose chloride, and CSF biofire were negative, but protein were high, 996 milligram per deciliter. CSF oligoclonal band was positive, and IgG index was positive. Other labs, routine labs of virology and vasculitic profile were normal. The EEG showed frontal intermittent rhythmic delta activity. The patient was admitted to ICU, received 7 days of IV methylprednisolone with no improvement. MRI with contrast and EEG were repeated. The EEG showed left slowing, while the MRI brain with contrast showed typical MS lesion, periventricular and subcortical, that doesn't explain the patient's symptoms. The patient received 5 days of IVIG with a total dose 2 gram per kg. There was partial improvement regarding the weakness, but no improvement regarding the field effect. MRI and EEG were repeated. The EEG became more or less normal. Also, the follow-up EEG was normal. But surprisingly, the MRI showed newly developed left occipital, cortical, and subcortical area of altered signal, eliciting high T2 and flare and low T1 with no restricted diffusion. This case. What's next? Our differential diagnosis was MS, vascular lesion, autoimmune, or post-infection status epilepticus. The MS was excluded as the lesion are not typical for MS, the attack not typical for MS, and the patient didn't improve on steroids. Vascular diagnosis was less likely as MRI brain diffusion and MRA were negative at the onset of the symptoms. Autoimmune diagnosis was suggested as the CSF biofire was negative and proteins were high. Status epilepticus is also a possible diagnosis. We found similar studies showing hyperintense lesions post-status epilepticus, and our patient reported having olfactory hallucination that persisted for 2 weeks before the onset of his symptoms. What's the next step in management? Thank you.
Did you want us to comment? Okay. So, can you hear me? Okay. So, I think if I understood the case correctly, you have a 40-some-year-old patient, had a many-year history of multiple sclerosis, 20-year history of multiple sclerosis, had done fairly well. So, the perception was EDSS score 0 without a lot of clinical relapses, so the patient's not on treatment. I'll make a comment that there's actually literature that admits that our neurologic exam is sometimes not very sensitive. So there's a lot of evidence that EDSS score of 0, which you would think means normal, if you do very detailed assessments, usually you can find some abnormalities, but I understand that the patient is doing well. Uh, it would surprise me for the score to be truly zero because you showed an MRI scan, which showed multiple periventricular lesions typical of MS, left middle cerebellar peduncle lesion I would usually associate with subtle ataxia, a little bit of a small periaqueductal lesion. Maybe the patient could have an internuclear ophthalmoplegia, with very careful. I know you said no, but sometimes you want to check for saccades. It could just be a very little bit of adduction slowing might be enough evidence for that, as well as a cervical cord lesion. So, you know, typical. The patient had been on interferon for some period of time. You took off. We don't talk about it a lot, but among all of our MS treatment options, beta interferons like Rebif or Avonex or even beta seron have been associated with seizure at times. But obviously, the patient was not on that medicine at the time of this event. So then the patient has a sudden change. Um, I'll be honest, I know that you used IV methylprednisolone and eventually intravenous immunoglobulin. I'm assuming because you thought there could be an MS relapse and you're trying to treat reduce the inflammation. But you had MRI evidence that there was no active inflammation. And in reality, the presentation of residual hemiparesis and visual field cut wouldn't be typical of an MS relapse. So I don't think it did any harm, but ultimately it wasn't helpful. So I think the lesson here is that sometimes, even though you have multiple sclerosis, that doesn't prevent you from having something else going on. We actually do know that the incidence of seizures and epilepsy and MS is a little bit higher than people without MS. Some people would estimate 3 to 4 times the risk. Seizures, a little bit more common with MS, not as common as with other inflammatory disorders like MOG antibody-associated disorder, much more likely to have seizures, not as much NMO spectrum disorder. I think I should stop talking, but just to say that it sounds like your patient did have focal seizures, perhaps with postictal phenomena. You did not always catch it, but at least on the most recent MRI, I would say this signal change does look most consistent with seizure to me. But no, you don't like it?
Looks like MS to me.
Are you joking?
You said it didn't look like you said it was seizures.
That?
Well,
So, okay, no, actually, it would be nice to see the images at the level of the hippocampus and olfactory cortex if we could. But the seizures can generate signal change in the cortex, especially if status. It tends not to be as discrete as this. And it can also be caused by whatever is causing the seizure. So an area of infection or inflammation or encephalitis or vascular can then trigger that to give more of a signal. But to me, this signal is too discrete to be generated from the seizures. And also, this is not a location where you would expect olfactory phenomena with the epilepsy. So that suggests something is going on temporally or in the inferior frontal cortex. So that means things are going on in different places, and that makes you think about all the adult things that I don't think about, but Dr. Ting thinks about all the time.
yeah, I had the same thoughts as Dr. Guyart. So if the first story of the olfactory auras, and you were saying that if you're going to propose that that is status epilepticus, it doesn't fit this hyperintensity in the posterior part of the brain. So I guess, to me, I always tell my trainees that the history is like 80 to 90% of the diagnosis. It's great to have the LP and the and yeah, it's great to have the images and even the EEG, but to me, if you really get a detailed history, that helps a lot with interpreting what you end up seeing on the imaging or the EEG. So when I saw briefly the EEG that I saw, I didn't see typically what you would expect someone who has status of having, temporal sharps or that would have auras, olfactory auras. I didn't see those focal epileptiform discharges. Maybe did you mention that there might be some like frontal slowing? Was that what you were saying? So, yeah.
Could we look at the
Yeah, if we
EEG
could look at the
again
EEG again.
and the imaging again, but a little bit more slowly? That would be great.
So if someone, you could argue that if we got imaging like this where it was hyper intense in the back, the radiologist will say, oh, think about the possibility of a seizure causing it. Usually it would be someone with truly clinical status epilepticus involving their visual cortex, et cetera, or with lots of spikes on the back of their EEG, posterior EEG. So the imaging to me doesn't really fit status epilepticus based on the clinical story and the history, although you're mentioning some of the field defect. I think that's more what the underlying cause here. And so when I loved your proposed differential diagnosis, I agree with that thought. And to me, of those choices, I'd be intrigued by the autoimmune potential there.
Really love to see a oblique coronal fast band echo or flare imaging of the hippocampus, because it looks like there is flare signal intensity in the right hippocampus, in the upper right-hand corner.
I might, maybe what would help, at least for me, would be getting a sense of exact time course of the different symptoms. So, for example, and again, it's just from the presentation, it did sound like there was a consistent visual field cut at some point, right? So you're describing a right homonymous hemianopsia. Obviously, that would localize to the left occipital lobe where you see some signal change. But I guess I don't yet know exactly sort of, was that different from the aura type presentations? I don't know how much time had elapsed between the spinal tap and the presentation and the MRI. The reason I say that, for instance, and it's sort of unusual, but I'm just thinking that MS has nothing to do with this that I can think of. This signal change is cortical, and really not really associated with an enhancing demyelinating lesion. So I might almost look at this case as maybe MS has nothing to do with it at this point. And now we just have a mysterious phenomenology of these seizure-like episodes and aura, some persistent neurological abnormalities, the evolution of some signal change on MRI. So for me, I'd almost, want, maybe to read, just to be very clear on sort of the time course and what is happening when. I think you already hinted, if you repeated the MRI and the signal was not so abnormal, that would be maybe fit more for something transient. The comment was maybe press. So the clinical picture isn't so typical of press. I think of a lot more headache, and usually I think of it as more bilateral and symmetric. Often, actually, one of the features of press actually is that it spares the occipital or calcarine cortex. It's usually actually a little bit more, but maybe.
I actually have another question for Dr. Guyard in the audience. Do you feel like the elevated protein is something you would see in a focal status, like that amount of elevation you would expect in focal status? Because I think that would also sway me a little bit away from status epilepticus as the only cause rather than a symptom of.
So there was a study that Orrin Davinsky did when he was an NIH fellow of tapping people after their seizures. And you could see as many as 10 or 20 white cells. But the protein was only minimally elevated, as I recall. So I think once you get to a certain level of elevation, you think of, I also don't know if that went along with the MS. I mean, not that that was an active thing, but in when you are not active in your MS, is your protein still elevated?
Was that LP during this posterior, like during this hospitalization for this? It wasn't an old LP, right?
He couldn't, till now, he couldn't dial, and his right side, the directions. At one point, he didn't know the right from the left, but he's improving on the way, on the whole. But still, his cell phone is.
Sounds like our IT department.
What's the next investigations?
I mean, I think you have to look at autoimmune phenomena. I mean, to me, if it's unexplained in this day and age, you need to look for bugs and inflammation.
I think, again, I'd be very curious about the exact time course. I think it was mid-December was the MRI that showed an abnormality. Is this a follow-up MRI or is this the same study? This is follow-up. How much time has passed? So you repeated the MRI scan 1 month later. This is a T2, not a T2 flare. There's still increased signal in that area, in the occipital area. I don't know, do you feel that the signal increase is increased compared to mid or better, improved?
Occipital lesion,
Yes.
newly developed, doesn't present in the previous MRI.
Oh, I see. So you're saying in mid-December is when the spinal tap and the seizure activity occurred. The imaging was normal at that time. And then now you've repeated just a few days ago, and now you see this signal change. Okay, and then the clinical picture you described, do you think the patient has been improving over the past month or not really?
The drift is improving on the right side. No, but still he has a problem with the ataxia, and the field is not that improving.
So you feel that
The EEG has improved. That's the only thing.
So the EEG you showed very briefly, there was EEG from mid-December showing some subtle asymmetry.
Yes, the first EEG showed some third activity, and then the second and third there was slowing, mostly posterior, with a few sharp waves, and then it's normalized.
Those EEGs were in December, and
Yeah.
then EEG in January at the time of the MRI you think looks normal.
Yes, yeah, oh yeah. There is very, if you look, carefully, there is mild slowing on the left side.
There's mild slowing on the left
Yeah, but
side.
on the whole, it's much better compared to the one 2 weeks ago.
Well, it's not the most typical, but I think you were careful to state that in December you did not detect any diffusion restriction. Is that correct?
Yes.
But there was no signal abnormality at all in December.
That's the fourth MRI, which showed this.
So you did 3 MRIs
Three
normal,
MRIs.
and only now this one shows this occipital abnormality. That is unusual. And restriction was checked on each of the previous MRIs. There was never any evidence of ischemia. I have to think more. Well, as long as the patient's not progressing, I mean, I didn't want to, it just seemed like this would not be a likely diagnosis, but there's one other diagnosis I think of if someone has a homonymous hemianopsia, but no imaging abnormality, okay? I do think sometimes of lobar dementia type, like deterioration, like CJD variants can do things like that. Yeah. So patients with Creutzfeldt-Jakob disease, you mentioned briefly in your talk of dementia. Obviously, we think of them as having rapidly progressive confusion and dementia. But there can be variants of CJD that are occipital or involving occipital cortex. So there's a Heidenhain variant of Creutzfeldt-Jakob disease that is primarily visual. Again, it just doesn't. I don't know if that fits this course. Well, that's what I'm saying. Although you're saying the EEG still has some abnormalities on it. Is that correct? Yeah. Yeah. I don't know. It's an interesting case. I don't like infection, I think, only because of the normal lumbar puncture. There was no pleocytosis. Yeah.
So
The last thing I would think would still be a stroke, just somehow. I don't know how to explain the absence of initial restriction, but the evolution of signal change with a permanent deficit, maybe I would think of stroke.
It's not MS. It's not a stroke.
I don't think it's MS.
I don't think it's postictal. I don't think it's status. So it's something else.
but he's improving.
I'm
He's
sure
im-
you have. I'm sure you have the answer.
Sorry?
Do you have the answer? No. But they're better because of your care.
Well, I think you were asking for next steps, and obviously we have been a little bit stumped about it. But I think that this imaging abnormality, you're telling me there's increased T2 signal on flare. There's no restriction of diffusion, no gadolinium enhancement of this area.
Yes, no gadolinium.
There's no enhancement. I think the only thing I would think of is, again, follow the imaging. You said clinically maybe improving. Maybe there'll be a little bit more of a clue on, I guess, MRI number 5 to see what happens.
But do you have CSF and serum sent off for antibodies?
No, that's what we're.
Yeah, I mean,
Antibody, yeah. The profile, autoimmune.
but the voltage gated. I mean,
we'll do this,
not just the NMDA, but the voltage gated ones, and then the other things. There is a gentleman at NIMH who looks at immune markers of undiagnosed immune encephalopathy. And he has a whole list of really obtuse and rare antibodies that can be related to specific cases.
Okay.
So it's just not the typical ones that we think of, but there's a whole host of other weird stuff that happens. I mean, this is someone in their 40s. They're not immune suppressed. So that makes it, I think, a little bit more likely.
Okay. Thank you very much. Thank you.
Thank you, Ola.